Registered nurse, future registered nurses, nursing students. My name is Joe Lewis. I'm a registered respiratory therapist times 20 years. You may recognize me from another YouTube channel titled Respiratory Coach. On that channel, I do everything I can to help aid the educational process for future respiratory therapists. I created this channel to help bridge the gap between respiratory therapy and nursing, to help fill some of the gaps for you as a registered nurse so that together we can all take care of our patients better with better outcomes. Now, this video is all about how the ventilator recognizes when the patient wants to take a breath during mechanical ventilation. It comes down to pressure versus flow triggering. That's what it's all about. If you like any portion of this video or find any value, hit the like button. Please subscribe and put questions in the comments below with your thoughts and any other topic you would like to see from me that can help you on the nursing side when it comes to respiratory therapy. All right, so today's topic is all about pressure versus flow trigger. You can see that I have it here on the board. First, we're going to be working through this, explaining what the difference between pressure and flow triggering is. And by the end of this, I hope you have a better understanding, if nothing else, of exactly how flow triggering works. Now, before we jump into it, we know that during mechanical ventilation, anything that starts the inspiratory phase is called a trigger. The ventilator can initiate an inspiration based off of a time trigger. If it's not a mandatory ventilator-controlled breath, time triggered, then it is going to be initiated by the patient. The two most common ways this happens is through a pressure trigger or a flow trigger. But what does it mean? What does this do for your patient? Which one is easier? And how do they work? Let's jump into it and talk about it. Now, the easier of these two to explain is obviously pressure trigger. Now, what you see here is this is 0, and this is a patient who has, let's say, a PEEP of 8 set, okay? Now, what pressure triggering is that the ventilator is going to use pressure changes to recognize when the patient is asking for a breath. Now, how does this work? Just like me and you are breathing right now, our diaphragm contracts at the beginning of inspiration. We get a signal from the respiratory center of the brain. It says, take a breath. The diaphragm drops and it creates a negative intrathoracic pressure. The same thing happens when you're on mechanical ventilation. As the diaphragm drops, it will cause a drop in pressure intrathoracically, which will then be transposed to the ventilator circuitry, and there will be a noticeable drop in pressure. If that drop in pressure is great enough, then the ventilator will recognize it as an inspiratory effort and will deliver whatever the said breath is stated to be given. Like if you're in assist control, then it will give a mandatory controlled breath. If you're in SIMV, then perhaps it allows the patient to breathe spontaneously. Same in CPAP or APRV or PAV or any of the other modes of mechanical ventilation. So this has really nothing to do with mode of mechanical ventilation. It's just, how does the ventilator recognize when the patient wants to take a breath? So here we go. We've got our pressure waveform here. We're on a PEEP of 8 right here. So this is our PEEP setting. And the baseline is here, just moving down here, right? Now the patient is going to initiate a breath. The diaphragm drops, pressure drops. When it reaches this preset determined pressure trigger state. Well, what does that mean, Joe? Well, it means whatever you have your pressure trigger set to. So let's say you have it set to -2. Well, that means if you're starting at 8, then this pressure trigger is going to be recognized in a drop of 2 centimeters of water pressure, which is going to take us down to 6. And the ventilator says, oh, you must want a breath. Then I'll give you one. And it returns back to baseline. This right here is the recognized patient pressure triggered, okay? Now, if we take this backwards and we do it another way, let's say the patient is breathing and they do something like this. Well, here you see where there was an effort to initiate a breath, but the change in pressure wasn't great enough to trigger the vent into recognizing that a breath is being attempted. And so there was no opening of the inspiratory valve and closing of the expiratory valve to allow the patient to either take a spontaneous breath or to give a mandatory breath. So this would be what we would call a failed or a missed trigger opportunity in the pressure control. Now, remember I told you that, let's say we're on -2. Well, I said -2 because that's kind of a base starting point. I'll tell you, Egan's says that the range is 0.5 up to 1.5. These are negative numbers, but then also up to 2 is acceptable. So really what you're looking for is about a pressure trigger of -1 to -2, and that's going to be below whatever the baseline is you have set. Now, what if I set it to -5? So let's just say we want to go there, right? Well, what that says is that now this patient is going to have to pull all the way down here to where it recognizes a 5 difference before a breath is given. So you can see where -5 is harder to trigger than -2. And so you want to know your normal values here because you don't want to have your patients trying to breathe when they can't because of an inappropriate pressure trigger. So understanding that -5 is less sensitive to the patient than -2 is important. Now that's pressure trigger, recognizing it's a drop in pressure to a preset level and a breath is delivered. Now, when we look at flow triggering, it gets a little bit more complicated, okay? Because flow triggering does not function off of a change in pressure. What it does operate off of is a recognition of a flow absence from the circuit. Let me say that again. It operates off of the ventilator recognizing. So the recognition of flow absence or missing from the ventilator circuit. Now on a waveform, this will look something like this. Let's say we have a breath like this that comes up and we come back to baseline. And then we get this little rise right here. And then that goes into maybe a spontaneous breath or something like that. It's this rise and flow right here because what happened? The diaphragm dropped. So you have your lungs here. Diaphragm goes down, diaphragm goes down. When that happens, flow comes into the airway and towards the patient. And so it looks like it's going to be on the inspiratory side because the flow is going this way. And the ventilator, when enough flow is missing, says, oh, this patient wants to take a breath. Let's let them breathe. Whether it's spontaneous or mandatory, again, it doesn't matter. But this is where the recognition happens. That doesn't really tell us how flow triggering works. So let's try to make this sense right here. Let's say this is a ventilator, okay? And you have a circuit that is going to a patient and then returning back to the ventilator. Let's say that this is inspiration and this is expiration. So the flow is going like this. Okay, now we know that anytime we are operating off of a flow trigger, we have to have a bias flow set. So when we talk about this and you talk about flow triggering, you have to understand that there's a bias flow. Now, what does a bias flow mean? Well, a bias flow is simply basically a set small level of flow that is constantly running through the circuit. So for example, let's say we have a bias flow set of 4 liters per minute. Well, that means that this ventilator is constantly allowing 4 liters per minute to flow through this circuit. 4 liters goes out, 4 liters comes back. Okay, this is how this normally works. Now, what happens when the patient initiates that breath? Remember, I told you, the diaphragm drops and flow is sucked in towards the patient. So if you have 4 liters running through here and the patient sucks in and draws flow into them, then guess what? There's no longer 4 that gets back. Now there may only be 2 liters that get back. Okay? Now the ventilator says, oh, I recognize that I'm missing some of my flow. Well, where did it go? Well, if it didn't come back, the only place it could have gone is to the patient. So the ventilator says, oh, then it's time to give a breath. The patient must be sipping on this tube or initiating a breath. That's where the missing flow went. So I need to allow this patient to breathe, or I need to administer a mandatory breath, depending on what mode we're in, right? So how do we know how much has to miss? Well, that's your flow trigger setting. So when you want to set this 1 to 2 liters per minute below your bias flow. Now that's easy to do because you set it on your ventilator, depending on what vent you're using, at 1 or 2 liters per minute. And what that is saying is that whatever the bias flow is set at, a drop in flow of 1 to 2 liters per minute will initiate a breath. So we go back to this example I was at back over here. Let's say we have a bias flow of 5 liters per minute. Okay? So we have a bias flow of 5 liters per minute. And we're supposed to set our flow trigger 1 to 2 liters per minute below that. So we say we're going to set it on 2. So we got a 2 liters per minute flow trigger set. Okay. Now, patient initiates a breath. They sip on some flow, and guess what comes back? Comes back here to the vent. Only 3 liters come back. That right there is a difference of 2, which is what we're set on, which tells the vent this patient is trying to take a breath. Now, what happens if we don't get, what happens if we get 4 liters back? So let's say 5 liters come out, the patient makes a weak effort, and we get 4 liters per minute back. 5 went out, 4 came back. Well, the difference now is only 1. 5 minus 4 is only 1. That's only a 1 liter per minute change in the bias flow. Well, we're set on a 2 liter per minute change. So guess what? The patient tried to take a breath. It wasn't a strong enough effort. It didn't remove enough flow from the circuit. Therefore, it's not recognized as a breath, and the ventilator is not going to do anything in response to it. This is also why when you look at some ventilators where you may be giving, I think for the most part we've kind of gotten away from this, but there are some facilities who are still utilizing small volume nebulizers ran off of the flow setting from the wall, from the flow meter, into a vent circuit with a small volume nebulizer to aerosolize albuterol or levobuterol or whatever it is we're aerosolizing these days. Okay? So let me show you how this happens, because if you've seen this and you know what I'm talking about, you have a patient on CPAP, they're breathing just fine, they got a respiratory rate of 12, their tidal volumes are 500, they look perfect, we're going to be getting them extubated soon, and then you give them a breathing treatment and they go apneic. All right, wait a second, why are they apneic? Well, let's show you what we're talking about. You have a bias flow set on 5 liters per minute, and you have a flow trigger set at 2 liters per minute. And then you come over here and you put in a nebulizer running on the wall at 8 liters per minute. How much is coming back on the expiratory side? 5 liters bias flow. This 8 liters per minute is running the whole time, so you have 13 liters coming back. But the ventilator does not know about this 8 liters per minute. It doesn't know that. It just knows that this is like there's just a lot of flow coming back. But it doesn't know that there's an external device that is adding flow to the device. All it's doing is measuring flow. And it doesn't really even care if there's an excessive amount of flow. It's just programmed to respond to an absence of flow. So your patient takes a breath. Let's say they sip out 3 liters per minute. That changes this from 13. Let's say they only get 10 back. Okay? But remember, the vent only knows about the 5 that went out. So it's looking for a drop to 3 liters per minute. And we only drop to 10, and the ventilator doesn't recognize the inspiratory efforts coming from the patient. Why? Because of all that additional flow that we have added into the circuit. So you have to understand that this is how flow triggering works. However much bias flow is going out, it is going to be compared to however much comes back. And if there's any missing, depending on where you have your setting at, then it's going to think that it is a breath, or it's going to say the patient's not trying to breathe. And that's how flow triggering works. A couple things we need to talk about before I wrap this up. Understand that auto PEEP will create problems and difficulty triggering in pressure or flow. Doesn't matter. It's traditionally thought that flow triggering is easier than pressure triggering because it takes less effort to remove a little bit of flow than it does create an actual pressure drop. That was kind of the original mentality when you talked and learned and the flow triggering came out. And if you've ever breathed on a ventilator, you could probably say, yeah, that was true. Egan's actually states that some of the newer softwares on these newer ventilators have kind of closed the gap between pressure and flow triggering. And so the old adage that flow was easier or better, still not any data out there with the new software with the ventilators that really supports that anymore. So it really doesn't matter. What does matter is that no matter if you're in pressure or in flow triggering, auto PEEP will make it harder for your patient to trigger a breath. So be on the lookout for that. Leaks. If you have a leak in your circuit, it will cause your pressure to drop, which could cause additional false triggering. So it could cause auto triggering because of the loss of pressure if you're in pressure trigger. If you have a leak and you're in flow trigger, then you're losing some of that flow out of that leak. And then again, it could cause auto triggering to happen. And so recognizing that leaks will cause auto triggering, potentially, while auto PEEP will cause missed triggering, missed triggers, or at least difficulty triggering. So, and then the last thing I want to say is understanding that changing your sensitivity does not change your effort from your patients unless you're making it easier for them to trigger a breath. So for example, you have a patient who's trying to take that breath and you notice missed triggers. And you say, I'm going to make this easier for them. Then in that situation, yes, sensitivity is going to help that patient generate a breath easier. What I mean by this statement is, I got an email recently and it said, I was wondering why they changed the pressure triggering. They turned it way down, like down to -10, because this patient was triggering a lot of breaths. And so they said, well, we'll just make them stop breathing by turning the sensitivity way down. And they decreased the sensitivity to -10. Now think about that. If we go back to our pressure waveform, if you're right here at 5 and you drop it to a -10, this person has to bring that all the way down here to -5. That's a difference, a pressure gradient difference of 10 before that breath is recognized. So they said they turned the pressure triggering to -10, and then that stopped all the extra breaths from happening. And that's true. But it did not solve that patient's neural drive and desire to breathe. So understand that if you have a patient who is triggering an excessive amount of volumes and maybe they're hyperventilating, there's probably a reason they are hyperventilating. Maybe they're a head injury or a neuro patient. Maybe they're trying to compensate for metabolic acidosis. For whatever reason, if a patient is trying to take an excessive amount of breaths, most likely there is a reason for it. Maybe our sedation levels are not correct. Maybe our mechanical ventilation settings are not correct, and their occlusion pressure and work of breathing and neural drive is very, very distressed. You have to figure out what is going on with that patient and understand that making the ventilator not respond to a patient who is actively trying to take a breath, well, let's just say that does not sound very humane to me. And so for the sake of humanity, let's find ways to treat that patient better. Let's find ways to figure out why they are initiating so many breaths and maybe solve that instead of just locking them out of being able to initiate a breath. That's my 2 cents on that issue. I hope you found this video helpful. I hope you have a better understanding of pressure triggering versus flow triggering. If you found any value in it, I would appreciate it if you'd hit that subscribe button, hit the like button, leave me a comment, even if it's a hate comment. I love reading them. A lot of them make me laugh, and they boost this channel and this video in the YouTube space. So I appreciate you. In the meantime, always remember and never ever forget it. Average is easy, so don't be it.